Hi, today we will talk about the need and tools to reach a correct diagnosis in order to reach the right treatment. My name is Aviram Zailer and I am a certified orthopedic surgeon and musculoskeletal pain expert. A lady named Fiona came into my office one morning and said that she needed to renew her prescription for insoles. For about several years, she had been suffering from excruciating pain in her lower leg that made her to stop dancing. She went to doctors including orthopedists and was treated with medications, insoles and physical therapy, even acupuncture. For the last 2 years, as it progressed, she stopped exercising at the gym. She had been told her problem is a difficult one to solve and she needed to get used to the pain and to change her life habits. She was transferred from operational position in the security forces to office job. She was depressed. She said that she began to understand that there is no escape but to get used to the pain and that there is probably no significant treatment. I stopped her and asked her to give me a chance. After completing asking questions, I checked her. She went out of my office 5 minutes later, dancing all the way down the hall. She went back to gym and her other activities without any limitation. As I found really important motives in Shrek movies for the right way to get the right diagnosis, I thought to use it to make it easier to remember. As in the Hippocrates Oath, we must abstain from any harm to patients. An essential step toward the right treatment is the right diagnosis. And I got lucky that day. The treatment was simple. So, musculoskeletal misdiagnoses are estimated as 5 to 70%, up to 30% in women and comorbidities. Imaging misdiagnosis rates are miserable. MRI of spine are estimated as 70% for false positive and false negative together. The option to change it is to take good medical history and relevant physical examination, and then to think. Well, our players here are the Cookie Man as a patient and Shrek as a physician. We must understand the whole picture of the patient.
You can find him in the middle.
To get there, the physician has two important toolboxes. The first one contains the diagnostic tools, and the second one is for treatments. Our diagnostic toolbox includes the right things to do so: medical history, physical examination, and adjuncts such as medical imaging. But the most important tool here is the thinking or the algorithm behind. Let's talk about backache, for example. While we hear the patient complains, we are trying to understand, first, who is the patient? Second, what is his complaints? Third, what are his expectations?
We need to locate the pain.
Upper part, middle or lower, or maybe diffuse? Is it in one side or both? Is there any radiating pain or other related complaints? If there is abdominal pain, we should check some other things. Try to find how it started. Just after waking up, or was it while standing up from a chair? Maybe it is after trauma. Was it with a high energy?
Is it preferred to stand up than to sit? And what about walking versus standing? Is the pain got worse during going up or down the stairs?
He sleep on his back, on the side, or maybe with a pillow between his knees. We can also use the PQRSTU mnemonics. And never forget the red flags.
While checking the patient, we should first look on his appearance.
Can he walk? Can he sit? Any bending, limping? Then ask him to point to where it hurts the most. The basics of orthopedic examination is look, feel, move, and special tests. Try to find his comfort zone, any influence of static position and dynamic moves on his pain. Compare between standing, sitting, and laying. Each position may give a clue about the origin of the pain. And never forget to check neurovascular. Only then we can use imaging and other adjuncts to guide our way. After collecting all the above, here becomes the real process, integrating all details and thinking. The integration is based mostly on anatomy, so we must be anatomy king. But what do I want from Shrek? Well, Shrek has the best way to become the anatomy king. To find the pain and to find its origin. Especially in the musculoskeletal system, there are two tools that are very helpful for having the right diagnosis. The onion carriage and the road to far, far away kingdom. Onion is for the layers of the body. While dealing with specific locations, at the pelvis, we should remember what structures are relevant, which bones, muscles, fascia, nerve, blood vessels, visceral organs. But the onion attitude is not enough. We should think on the road to far, far away, which of the previous structures goes to which direction. If we follow that in the right way, then we will get the right diagnosis. Back pain that got worse with abduction external rotation of the shoulder may involve the latissimus dorsi. If the lower back got worse with passive SLR, it might be sciatica or radiculopathy, depends on the accompanying signs and symptoms. If it gets worse only with active SLR, perhaps it is piriformis syndrome or other muscular tightness. That we can check with the hip rotation, for example, or adduction. Adduction plus external rotation may be the gluteus maximus ITB complex, while adduction alone, more probably gluteus medius ITB, while adduction and internal rotation suggest piriformis. But there is also the test for FAI and anterior labral tear and iliopsoas tendinitis. Well, that depends where the patient feels the pain and other symptoms. We should think of the different patterns of pain. While axial load would be positive for bone or joint issues, stretching would be more specific for soft tissue. If the pain cannot be made with maneuvers, it might be a visceral pain, for example, posterior arm pain in a heart attack. If there was a wound at the foot and a week after there is a lower leg pain, it might be infection. A migratory arthritis might be infection or rheumatic disease. Relevant history taking, including family background, might help. Other findings such as psoriasis and nail pitting may take us to a more specific way. Although by exception, as we got the whole picture, we should ask ourselves, is there any subconscious process or any secondary benefit? There are specific tests that we might consider then. The road to far, far away does not stop there. We should look for the primary cause for the pain. If he is a student, sleep almost only on his back, and is painful going upstairs, has a tight band of the longissimus thoracic with tenderness indicated to his complaints, maybe we should look for the ergonomics around his studying. Is his screen on his eyes level? Or if he has a sore ITB, it might be because he forget to stretch after running, or else maybe his knee went out of balance due to increased joint fluid. Keep in mind that we should look for the primary issue, else we can treat him even well, but the pain will come back. All that just to prevent us from barking up the wrong tree.
So, what we have learned today?
First, understand the patient and his problem. Second, we must be the anatomy king. And then to use the onion carriage and the road to far, far away to make the right diagnosis. Only then we can use our second toolbox and to treat the right problem. I hope that presentation will help you to remember it is all about the DD. Thanks for watching.